I would like to then introduce our next speaker, Irina Bancos from the Rochester in the United States. Irina.
Thank you so much. And I'll do the same exercise of sharing my screen, and hopefully I'm not sharing something I should not.
No, I see your share is on the full screen. Please, the floor is yours.
Perfect. And I'll start right away with two cases to make it a bit more real. And these are my patients I've seen sometimes over the last several years. Patient number one is a 47-year-old woman with history of surgically treated meningioma. She was diagnosed with a large meningioma 8 months ago. Surgery was done 3 months ago. And post-operatively, her neurology team initiated her on dexamethasone 4 milligrams twice a day. Currently, she is on dexamethasone 1 milligram twice daily, and she is referred to endocrine clinic because cortisol was measured and it was undetectable. So that's patient number one. Patient number two is a 53-year-old woman with history of rheumatoid arthritis. She used prednisone intermittently, starting sometimes 4 years prior to her endocrine evaluation. And then she used prednisone daily, continuous use, at around 10 milligrams or so each morning for the last 18 months. 6 months ago, she was initiated on a non-steroid agent for her rheumatoid arthritis, and she is considered controlled. So prednisone is no longer needed to control rheumatoid arthritis, but she had multiple failure attempts to discontinue prednisone for the last 4 months due to extreme fatigue, nausea, myalgias, and arthralgia. So this is why she is in the endocrine clinic. I just want to point out for the purpose of this discussion that the first patient is on dexamethasone 1 milligram twice daily, and the second one is on prednisone 10 milligrams each morning. So both of them are on supraphysiological glucocorticoid use. So let's concentrate on patient number one first. So this is our first audience question. To remind you, this patient has been on dexamethasone for 3 months and currently on 1 milligram twice a day. Neurology recommends just to decrease it to 1 milligram dexamethasone for 1 week and then stop. What would you recommend? Would you recommend measuring cortisol 1 week after dexamethasone cessation? Would you recommend continuing dexamethasone tapered to a smaller dose, 0.5 milligrams, and then measure cortisol? C would be, once dexamethasone therapy is completed, initiate hydrocortisone therapy, 15 milligrams on waking and 5 milligrams in early afternoon. Or once dexamethasone is discontinued, start prednisone therapy, 10 milligrams each morning. So your answers would guide the next discussion of recommendations. Okay, so the most frequent answer was 3 to switch to hydrocortisone therapy, 15 on waking, 5 in afternoon. And the next one was to just taper down to 0.5 milligrams. Well, that's great. We'll have, because I would have chosen something different. So we'll talk about it. So let's review. As you recall, this patient had cortisol measured while still taking dexamethasone 1 milligram twice a day. This panel reviews cortisol and ACTH measurements depending on use of glucocorticoids and whether it's supraphysiological or physiological. So the panel on the left is where our patient number one is currently situated. She is treated with supraphysiological glucocorticoids. So it'd be no surprise to find cortisol being very low in this case. The panel in the middle describes evolution of HPA axis while patients are treated with physiological glucocorticoid use. For example, 5 milligrams each morning of prednisone or hydrocortisone, 20 to 25 milligrams a day. And the panel on the right illustrates normal ACTH cortisol production after stopping exogenous glucocorticoids. So again, our patient is currently in the very first panel, so in the journey of her glucocorticoid taper. And this gives me an opportunity to discuss recommendation 2.4, that we recommend against routine testing for adrenal insufficiency in patients on supraphysiological doses of glucocorticoids, or if they are still in need of glucocorticoid treatment for the underlying disease. So testing for adrenal insufficiency is not necessary in these cases. Let's review glucocorticoid potency. So this table outlines the most common glucocorticoids prescribed, the equivalent dose, glucocorticoid potency, the plasma and biological half-life. Our patient is currently on dexamethasone, which is a long-acting glucocorticoid with highest potency. Guidelines recommend or suggest that patients taking long-acting glucocorticoids, such as dexamethasone or betamethasone, should be switched to a shorter-acting glucocorticoid, such as hydrocortisone or prednisone, when long-acting glucocorticoids are no longer needed. Because glucocorticoid potency does impact the likelihood of adrenal recovery and also the accuracy of your testing. So in this particular case, what I would have chosen would be actually the least popular answer, and it's answer D. Once dexamethasone therapy is completed, start prednisone therapy 10 milligrams each morning. Why? Because guidelines recommend to switch from long-acting to intermediate or short-acting glucocorticoid, and prednisone is one of them. But also because I do not think this patient would do well on physiological dose of glucocorticoid. It would not be wrong to switch to hydrocortisone, 15 milligrams on waking and 5 milligrams in early afternoon, according to the guidelines. This was the most popular answer as well, so this is what you would have chosen. But I would be concerned that after 3 months of supraphysiological long-acting glucocorticoid, she would develop glucocorticoid withdrawal. And this is exactly what we're going to talk next, glucocorticoid withdrawal. And I would use, to illustrate the concepts of glucocorticoid withdrawal, the case of my patient number 2. To remind you, this is a patient with rheumatoid arthritis who has been on prednisone for 4 years, but continuously and supraphysiologically so at 10 milligrams each morning for 18 months. And this is the patient who kept trying to discontinue prednisone or to decrease it and is unable to do so because of fatigue, nausea, myalgia, and arthralgia. I would like to talk about glucocorticoid withdrawal syndrome. We see it quite often, and I would say it's the biggest challenge in the adrenal clinic if we are seeing people with glucocorticoid-induced adrenal insufficiency. There are certain differences and similarities in how glucocorticoid withdrawal, adrenal insufficiency, or underlying condition presents. Glucocorticoid withdrawal syndrome is a clinical syndrome that has symptoms overlapping with those with untreated adrenal insufficiency or rheumatoid arthritis, for example, in this case. The most common symptoms of withdrawal are fatigue, nausea, muscle and joint aches, sleep disturbances, and mood changes. When does glucocorticoid withdrawal occur? It usually occurs when the patient is still on supraphysiological dose of glucocorticoid. And it occurs because of a relative decline in glucocorticoid exposure. As such, Cushingoid features are still quite common in patients with glucocorticoid withdrawal because they just recently started their taper down towards physiological dose. And it usually happens at any point during glucocorticoid taper, and usually when prednisone is decreased under 15 milligrams a day. Testing is not recommended in these cases. And risk of adrenal crisis is unlikely because usually these patients are on supraphysiological glucocorticoids. So we're coming to our next audience question here. So this is patient number 2, 18 months history of prednisone 10 milligrams each morning, a bit longer intermittently for 4 years before that. Symptoms of fatigue, nausea, arthralgia, myalgia, every time prednisone is decreased under 10 milligrams daily. So what would you do here? Would you switch temporarily to dexamethasone 0.5 milligrams twice a day and then reattempt the taper? Would you advise a slow taper of prednisone, let's say 1 milligram decrease every 1 to 2 weeks? Would you switch to hydrocortisone taper starting to at 20 milligrams twice a day? or refer back to rheumatologist due to high suspicion that symptoms are due to uncontrolled rheumatoid arthritis rather than glucocorticoid withdrawal syndrome. Okay, so the most popular answer here is slow taper of prednisone by 1 milligram decrease every 1 to 2 weeks, followed by switch to hydrocortisone 20 twice a day. Thank you for that. So let's review what actually happened with this patient and compare it with a guidelines recommendation. So first, what is the recommendation 2.3? We recommend consideration of glucocorticoid withdrawal syndrome that may occur during glucocorticoid taper. And when it is severe, glucocorticoid dose can be temporarily increased to the most recent one that was tolerated, and the duration of glucocorticoid taper could be increased. And I want to show you what happened with this patient from the time that she was in an endocrine clinic until recovery. So if you look at this table, when we saw each other, she was on 10 milligrams each morning. We decided not to test cortisol level because she was on supraphysiological glucocorticoids, so the pre-test probability for adrenal insufficiency was 100%. At that time, we performed a very intense counseling of what's normal glucocorticoid withdrawal was, and she wanted to go ahead and decrease by 1 milligram prednisone down every couple of weeks until she reached that 5 milligrams prednisone physiological dose. It took her 2 months to decrease prednisone to 8 milligrams. She was still not tested. Glucocorticoid withdrawal symptoms were still there, but she was able to tolerate those because she knew that they were not the sign of something terrible going on. By 4 months, she decreased prednisone to 6 milligrams each morning, still not tested. Then we did test at 6 months when she was on prednisone 5 milligrams each morning. But, and at that time, she had cortisol of 2.9 microns per deciliter, so clearly still suggestive of adrenal atrophy. Because her glucocorticoid withdrawal symptoms at that time were a bit more severe than she was able to tolerate, she went back up to 6 milligrams for another couple of months. And then she tried again by 11 months to decrease it to 5 milligrams. And at that point, she no longer had glucocorticoid withdrawal symptoms, but still had adrenal insufficiency. By 12 months, her cortisol in the morning went to 8.2, and by 14 months, when her cortisol was 11.3 microns per deciliter, her prednisone was stopped, and she was advised she no longer had glucocorticoid-induced adrenal insufficiency. So I would agree with the majority of you that a slow taper of prednisone in this particular situations work the best. Switching to hydrocortisone taper probably would work fine, but in general, patients are not very happy to go to twice-a-day dosing after they've been on prednisone only once a day. And ultimately, there are no data to suggest that switch to hydrocortisone would increase the time towards recovery of function. So without this, and in my own personal experience, people do better with prednisone, so I would not switch to hydrocortisone just to allow for a better quality of life while tapering. Okay, we have just a few more concepts to go through. And here come the recommendation 2.6 or 2.7. So our patient reached physiological dose of prednisone 5 milligrams each morning by around 12 months after we started. 2.6 recommendation suggests that patients on physiological daily dose equivalent as our patient, again, 5 milligrams of prednisone a day, and aiming to discontinue glucocorticoid therapy, either continue to gradually taper glucocorticoid dose while being monitored clinically for signs and symptoms of adrenal insufficiency, or, as our patient had, be tested with a morning serum cortisol. If the second choice is desired, so confirmation of HPA axis recovery, we recommend morning serum cortisol as a first test. So we do not recommend casintropin stimulation test. And the value of morning serum cortisol should be considered as a continuum, with higher values more indicative of HPA axis recovery. So because we endocrinologists love our cutoff, we do provide some cutoffs. If cortisol in the morning, 24 hours off, prednisone is 10 microns per deciliter or above, we suggest stopping glucocorticoids as HPA recovery occurred. If cortisol is below 5 microns per deciliter, that would be below 150 nanomoles per liter, we do not think that it is likely for the patient to recover in the next 3 months. So we would continue glucocorticoid therapy for the next 3 months and then retest. But if the cortisol levels are between 5 microns per deciliter and 10, we continue glucocorticoids, but retest earlier in few weeks because recovery is likely imminent or more imminent than if cortisol is lower. I just want to point out that if you calculate the ratio between 150 nanomoles per liter and 5 microns per deciliter, or between 300 nanomoles per liter and 10, it doesn't quite, it's not quite consistent with a conversion of 27:1. And this is to highlight that we wanted a round number that people would remember, and to highlight that this is really just a suggestion, these cutoffs. I think clinical examination and patient symptoms are as important.